Implant dentistry has gone through many innovative changes over the past few years, and one of the most prominent is CT diagnostics. We can now use a CAT scan for three-dimensional implant treatment planning and actual surgical placement of our dental implants. Today's patient had a unique situation. She had periodontally involved maxillary anterior teeth. She had significant bone loss around these teeth and mobility. And her main concern was that she would not be able to function for any length of time. She knew she was going to lose those teeth. But a bigger concern was her aesthetics concern, meaning she would have to come into the office, the dentist would have to remove her teeth, and she would leave the office either with nothing, which was not acceptable, or something removable, which was equally distasteful to her. So as she came in, she wanted to determine if we could immediately place implants and give her some immediate restoration of her maxillary 4 anterior teeth. So a CT scan was completed on this patient using a guide. This guide has gutta percha embedded in it and is used to establish a plane for the CAT scan. A CAT scan is then done, and using the Nobel Guide CT scanning software, we were able to create a three-dimensional image for this patient and actually virtually place our dental implants in the patient prior to any surgical intervention on her. So we made three-dimensional models, and we determined whether or not we could place implants in the anterior premaxilla. And we found that we could successfully place the implants, allowing ideal separation between the implants and nice depth placement of the dental implants. We would place 3.5 millimeter diameter implants in the lateral incisor areas and 4.3 millimeter diameter implants in the two central regions. However, Nobel Guide tells us that placing implants in immediate extraction sites is a difficult, if not challenging, endeavor. We knew preoperatively that the roots of the teeth had resorbed significantly, so we felt we would be obliterating the sockets completely in the placement of the dental implants. But first and foremost, we had to design a surgical guide that would allow us to correctly place the Nobel BioCare dental implants, replace select dental implants, in a relatively tight area. To do this, we would create a surgical stent in the dimensions regulated by the parent company, but the challenge would be the metal sleeves or rings that would allow us to place the implants in the correct position. How could we stabilize those rings appropriately to use it as a surgical guide? The acrylic that was used would be an overlay similar to a bite splint. It would have to be stable, not move, and allow us to position the implants correctly. So let's look at our patient right now. This is the preoperative photograph of her high smile line. The lateral incisors and two maxillary central incisors are fairly mobile. She has some real concerns with aesthetics and function. She'll tell you that she would not be able to bite into a breadstick or feel comfortable going to a restaurant. She felt that she was going to lose those two teeth shortly, which affected her emotionally. Right lateral and left lateral views show an adequate smile line. We do see the triangles of the teeth, which is aesthetic. Her basic contours are not bad, but we can see a certain amount of recession along her natural dentition. Our focus today is going to be on the 4 maxillary anterior teeth, number 7, 8, 9, and 10. You can see in this radiograph that the roots have shortened immensely, creating the mobility that our patient was most concerned with. As I mentioned earlier, we weren't necessarily concerned after extraction of those teeth to place implants in those socket sites because we would obliterate those sockets completely. The CT scan was very, very important in this case to determine whether or not we could actually do this case successfully and predictably. And being able to virtually place the implants and determine prosthetic position is a tremendous advantage. We were no longer guessing on where we wanted to place the implants or guessing where the final restoration would be. We knew it all before we ever touched the patient. This view shows the palatal aspect, and you can see that a dentist had splinted those 4 anterior teeth to her cuspid teeth to give her some stability, but those teeth were fairly mobile. After the CAT scan was completed and the Nobel Guide CT scanning software was used, the dental laboratory actually fabricated a model. Again, this is prior to me ever touching the patient, to determine the correct position or ideal position of the dental implants. Again, 3.5 millimeter replace implants in the lateral incisor areas, and 4.3 replace select implants in the 2 central incisor areas. This is all done preoperatively by our dental laboratory. We would use transitional abutments in this situation. You can see they're conical in shape, which would allow us to place our final transitional splinted crowns the day of surgery. So these are transitional Nobel BioCare abutments that, again, this is all done preoperatively by the dental laboratory. They are determining ideal position for ideal final aesthetics of the final crowns. Here the dental laboratory fabricated 4 transitional crowns that were splinted together that would be placed immediately after implant placement, surgical placement, using the surgical guide that we'll illustrate more clearly in a little bit. So the dental laboratory has a very important role in determining final aesthetics. Now, we wanted to use the patient's own natural incisal lines and basic contours in determining length and position as possible with the amount of bone that we had. Here we're using a periotome to simply break the periodontal ligaments around the teeth that we are going to extract. And let's run a little video here. On the extraction, we want very careful extraction. We take a lot of time in removing of the teeth so as not to disturb the buccal plate at all. We have a nice clean extraction, trying to, again, maintain the interdental papilla as possible. We're simply removing those 4 mobile anterior teeth with the shortened roots, and you can see I'm not having any difficulty at all simply removing these teeth. We will not use a scalpel in this situation. Again, we're trying to maintain that interdental papilla as much as possible to maintain our final aesthetic results. Nice, clean extraction. And you can see after the extraction we have viable bone to work with, very shallow socket sites, so I feel very comfortable in the placement of our dental implants. We have pretty good width also because it's an immediate extraction situation. The buccal plate is really intact and should turn out to be a nice situation for us. Interdental papilla, trying to maintain those triangles as much as possible, is a critical part in the final aesthetics for this patient. Here the radiograph illustrates the extraction sockets, and again you can see that they are relatively shallow and they will be obliterated in the final osteotomies. The septal bone is maintained in this situation. It's critical that we maintain that septal bone so that we can maintain tissue height and keep the nice interdental triangles as possible. Here we see the 4 roots that were removed, had been internally or externally resorbed. There just wasn't very much to work with for this patient, and you could see her concern, being a relatively young person, of losing your 4, the concern of losing your 4 natural teeth has to be a very psychologically traumatic experience. So, this is very important. We fabricate a surgical guide based on the CT diagnostics of the Nobel Guide scanning software. The laboratory is able to stabilize the 4 rings, which are surgical guide rings, quite nicely. But you can see there's no set pins to hold this appliance in place. It's more like a precision occlusal guard that will allow us stability and allow us to use the rings in the surgical placement of our dental implants. Here's an occlusal view of the same. We have a tight situation, 2 laterals and 2 central incisors, but we were able to use the computer to properly angle and position our dental implants, so we knew that we could use a surgical guide in this situation to ideally place the implants. If we were unable to use this, or if we were unable to place the rings or to stabilize them correctly, we would probably do this case freehand. Doing the case freehand would obviously create some discrepancy or disharmony and probably would not allow us to load the implants immediately as easily and as predictably as we were able to do in this situation by using a very stable surgical guide. Close-up view of the 4 rings. You can see the separation that will be created from the implants. We have plenty of room to place the implants in the correct position. Here we're simply placing or snapping in the maxillary surgical guide, again created by the dental laboratory. They've already created models and positioned the final teeth where they ideally need to be. This occlusal or this surgical guide fits on the occlusal of the teeth and needs to be stable. It cannot rock in the position, so it's really snug and kind of snaps into position. An occlusal view of the same. Now we're using different keys with the Nobel Guide system that will allow us to initially do our 2mm pilot drill to the correct depth. Now, these surgical guides are very precisely made, and they increase the distance from the crest of the bone to the top of the surgical guide by 10 millimeters. So our surgical drills need to be compensated for this extension of the surgical guide itself. So here we're simply placing a 2mm key into our 3.5 millimeter ring, and we're going to use our 2mm drill, initiating drill or pilot drill, to make our initial osteotomy. Now we've also predetermined depth of all of our implants, so we know exactly how deep we want each of the implants to be. We know their depth and their width precisely. It's a very precise system. You can see that the initiating drill or the pilot drill has markings on them. We know we're going to a certain depth, 13 millimeters, and we'll go to the proper line. And here we'll show a video illustrating the pilot drill, simply drilling to the stop that's created in the drill itself. We go to depth and stop. The difference of the crestal bone to the top or the occlusal part of the surgical guide has been predetermined. Here I'm using paralleling pins to determine our position, to make sure to double check that everything is going according to plan. This next video will illustrate the use of a 3.5 taper drill, again going to depth, and this is real time, and you can see how real simple this procedure is. We're simply going in and out of the osteotomy site, creating our implant site. This video illustrates we're using a key for the 4.3 millimeter central incisors. This key is 3.5 millimeters in diameter. So we use the 3.5 millimeter drill to drill to proper depth, again 13 millimeters. Here we're using paralleling pins, again, just to take a look and make sure that we're in the correct position, that we feel comfortable with everything we're doing at this time. A radiograph is taken. We're not coming too close to the natural teeth. The implants are spaced properly. You can see in this radiograph the dimension of the paralleling pin shows that we will have adequate spacing between the implants for ideal healing, integration of the implants. The next video is the next step. We're using a 4.3 taper drill to depth, and now we're going to use longer attachments into the implant so that we can actually place the implants through the keys, through the rings that are predetermined. Now you can see that these are a little bit longer than normal transferring copings with the replaced system. Again, everything is very precise in the system. It's very exact, and the length compensates for the thickness of the surgical guide, the rings, and the level of the crestal bone. Here we see a 3.5 replace select implant with the abutment attachment, which will allow us to place the implant in the correct position. And this next video shows we're hand placing the implant, threading it right through the preset ring. So we're placing this implant in the precise position that the dental laboratory envisioned us to place it. And we're going all the way to the hub. You can see the little markings, the little dots in the replace system. We want one of those dots to be towards the facial. That's where one of the lobes is facing towards the facial, which will allow us better final abutment creation and better aesthetics in the long run. So that little dot is facing towards the facial. And here's a close-up view of that. You can see we went all the way to the top. Very precise, very exact, very difficult to make an error in this situation. The next video will show we're removing those little abutments, seating surgical abutments, and you can see how we compensated for the length of the surgical guide. And what we're doing now is simply using pins that will lock the surgical guide in place precisely. So now this surgical guide can't move at all. We can adjust it either way to make sure that we have a complete seat prior to placement of our 4.3 millimeter diameter implants in the central incisor areas. So we have great stability of this surgical guide. It's not going to go anywhere. Now we're taking our 4.3 millimeter implant, replace implant, again with a 10 millimeter long surgical abutment that will be used and to thread the implant through the surgical rings into the osteotomy site. Again, the small little dots are facing towards the facial, which indicate that one of the 3 lobes with this system are facing towards the facial. Here we're doing the same with tooth number 9. And you can see immediately upon removal of those surgical abutments and the surgical guide, the implants are ideally placed based on the CT scan that we had taken and the CT diagnostics that I had created in engineering this case. Interdental papilla is in good position. We're at good bone height. We're going to place the transitional abutments in position. They're conically shaped, so it allows us a little bit of flexibility of the transitional splinted crowns. Close-up view, and you can see there's no sutures here, and this is immediately upon implant placement and seating of those transitional abutments. Going back, the dental laboratory had given us this same positioning of the implants on a model prior to me ever touching the patient. Immediate seating of the transitional crowns. Again, they are splinted for security. And you can see the tissue is a little bit red, a little bit raw yet. But again, that was the day of. Here is 2 weeks after. You can see how the tissues are starting to contour a little bit. Still not ideal. You can see the little purplish of the gingiva and the lateral incisor areas, but that area has been traumatized quite a bit over a number of years, and then traumatized again when we extracted the teeth and placed the implants. So I'm not overly concerned with that. We're just trying to create some interdental papilla for this woman. And again, a smile line immediately on cementation or placement of the crowns, temporary crowns. Now, after approximately 4 months of integration, we used our standard impression technique to fabricate our final zirconia abutments. So we take a normal impression, and the laboratory will then do their artistry to create 4 single zirconia crowns. Here you can see the zirconia abutments in place. They are torqued into position, and I put a little cavit over those screw holes. Now, tooth number 9 is a little bit raw, a little bit inflamed from the transitional or maybe some excess cement in that area. But as we'll see, the tissue will heal up nicely once we get everything in position. The implant crowns are zirconia, final zirconia implant crowns are cemented. We have fairly good emergence profile, fairly good interdental papilla. Again, this was recent after cementation, a few days after cementation, so the tissue still has some responding to do. An occlusal view of the same. These are 4 individual zirconia crowns. Final radiograph shows nice positioning, nice separation of the implants. We're not impinging on the natural teeth. And this was all predetermined using the CAT scan or the CT scan to diagnose and surgically place the implants. Virtually placing the implants in this situation gave us a tremendous advantage over freehanding this case. Right and left lateral smile lines. And I think we achieved a decent final aesthetic. I know we really improved the quality of life of this patient. She feels comfortable. Her comments were she feels very comfortable going out with her friends, having a meal, biting into a breadstick, biting into a bagel, something hard, and she feels much more confident in dating and kissing. It's a real improvement in the quality of her life. So before and after, I think we achieved a very, very nice end result. Not ideal. We're dealing with a situation that is very complicated, very difficult. There's a lot of emotion involved, but we did achieve a wonderful end result for this beautiful woman.
For Noble Vision, I'm Lila Lazarus. You may not realize how valuable your teeth are until you're about to lose them. Then you won't want to go one day without your teeth. Jennifer Latta thought her life was over.
I didn't want to get out of bed. I didn't want to do anything.
She didn't want to go out in public.
I didn't want to go to family functions. I haven't wanted to go to, even be around my family, let alone my friends.
She was convinced she'd never smile again.
I cried a lot, I walked around like in a lot of fear for a long, long, long time.
Jennifer's gums were damaged in childhood. The result? Jennifer's 4 front teeth were about to fall out, destroyed at the roots. At age 38, she was hiding from the world.
Oh, geez, forget it. There's no dating. I mean, why would I can't kiss anybody. I don't want to lose a tooth.
She wouldn't even go into a restaurant.
I didn't want to go out in public and eat. I was afraid that one of my teeth would fall out.
When she speaks, she often covers her mouth. But Jennifer hears about a solution.
The whole idea behind this was not to have to get dentures, especially, I'm not even 40 yet.
Jennifer? New teeth the very same day. But she's worried.
Is it going to look like me? Is it going to look, is it going to look like me anymore? Am I going to look like the same person?
It will. In fact, in one day, Jennifer will be given a permanent smile.
It's not a difficult procedure, and they can have their smile the same day.
First, the doctor does a CAT scan to get a 3D image of her entire jaw. Then a computer generates a blueprint of Jennifer's virtual smile. That blueprint is sent to the laboratory, where a complete model of perfectly fitted teeth are created.
I was able to virtually place the implants and restore the teeth, actually make teeth, before we ever touched her. We placed our implants and gave her teeth that same day. In about an hour, she left the office with her smile intact. Our technology today is just amazing. Being able to place final teeth, give the patient a smile when they leave the office with just local numbing, not a big deal, not a hard surgery. It's an incredible experience for both the doctor and for the patient.
Jennifer may have walked in with a lot of reservations, but she walked out with a new smile and a whole new view of life.
I love it. I love my smile.
She hadn't eaten anything crunchy in 5 years. But really the best part is just showing off her smile.
I'm thrilled. I am. I'm very thrilled with it, yeah.